Now we're moving. Sorry. Now we're moving on to the removal of the larynx. Now the larynx, or the voice box, is going to be located in this region. We want to, if at all possible, keep our blood vessels intact. So there are two different ways that we can go about this. One, we can start our blunt dissection and start removing as many of the muscles around the larynx as possible. Again, we're just doing our blunt dissection technique, keeping the tips of the scissors up. And as you can see, it doesn't take more than a couple of moments for us to expose the larynx. I can take my scalpel. Since this is a cartilage tissue, and just actually shave some of that down. Again, I'm being very careful not to get too close. Not to get too close to the blood vessel, so I'm going to employ my forceps along with my scalpel, and just peeling back some of that connective tissue. Going to do the same thing on the other side. Trying as best we can to stay away from those blood vessels. There's our carotid artery. Definitely want to stay away from that. Okay. So now I have most of the larynx exposed, but I'm not able to see everything that I need to. In order to do that, we are going to have to partially remove the larynx. This is kind of a brute force technique, but it seems to work very well. The first thing you want to do is palpate under the chin to see if you can find the hyoid bone. The hyoid bone is the base of support for the tongue. It's also attached to the thyroid cartilage of the larynx, and during swallowing, the tongue contracts, which elevates the hyoid bone, which elevates the thyroid cartilage, which causes a smaller piece of cartilage called the epiglottis to close over the opening to the trachea. I'm having a little bit of difficulty finding this. There's still a lot of tissue, but normally it's going to be probably about the width of the tip of your finger up. The reason we're looking for the hyoid bone is so that we don't accidentally cut off the top of the epiglottis. So we're going to say that the the hyoid bone's right about here. So I'm going to go up just a little bit further. And again, like I said, this is kind of a brute force technique. And I'm just shoving that scalpel all the way in until I hit bone. And then I will bring it laterally, reinsert, bring it laterally, and now just going to Bring it down on either side of the larynx. Cut down as far as I can. My finger in there and see if I can pull it out. If not, find out where the tissues are that are holding it in place. Cut through those. Through those. And notice I'm staying as close to the larynx as possible. I don't want to go too far out because we are going to be looking for salivary glands, and they're right in this region. So we don't want to cut too far away from the larynx. And just using my scalpel to gently remove some of that connective tissue. Get in there. See if I can almost, you can see a little bit of the pharynx back in there, and that's the tissue that's holding it in place. So I'm just going to cut straight across, cut down a little bit, cut down a little bit, and see if this works. I feel part of that hyoid bone. I'm catching on it right now. No, still stuck in there. Coming in. Cutting a little bit more. Coming in. Cutting a little bit more. Oh, I just heard it snap. And now it should come out with no problem. And if you take a look right down inside, that little tip right there, that's the tip of the epiglottis. So that's what we were trying to save all along. From this point out, all you need to do is scrape away all of the remaining soft tissues surrounding the larynx and identify the pieces of cartilage. The easiest way to remove a lot of this excess tissue is, again, just the blunt dissection. All I'm doing is putting my scissors in there. And you really don't have to go very far because the top of the larynx is right here. All of this is muscle connected to esophagus. Again, the reason we took out so much more than what we actually needed the easiest way to remove a lot of the excess tissue from the larynx is just with a blunt dissection. Just sticking my scissors under the tissue and gently separating it from the cartilage that is making up the larynx. The top of the larynx is actually right here. We needed to remove the rest of this tissue so that we preserved the epiglottis, which we can see right there. If we had just cut even with the top of the larynx, we would have shaved off the tip of that. So just take some time, do your blunt dissection to help get rid of a lot of that tissue. Once you find the top, you can actually either just use some scissors or your scalpel to shave a little bit more of that tissue off. Again, always angle the blade up, always keep the tip of the knife up. Better to have to come back and shave a little bit more than actually shave off too much. And I'm just keeping my knife, my scalpel angled a little bit to make sure that I don't hit that epiglottis. Now all I'm doing is just scraping some of that soft tissue off. And I'll do that all the way around on both sides until I can get the larynx itself exposed. Now, down here, we would find a piece of cartilage called the cricoid cartilage. The cricoid is what connects the larynx to the trachea. So again, we're going to just very gently start scraping off some of that tissue until we are able to fully see the cricoid cartilage. Those primaries would be the mouth, the pharynx, which was located on the posterior and superior portions of the larynx before we removed it, and the esophagus, which is this hollow muscular tube that we find on the posterior surface of the trachea. So these are all primary digestive system or gastrointestinal tract organs. These form a portion of the tube, our digestive system, that extends from the mouth to the anus. We also find 3 accessory organs: the teeth, the tongue, and we can see a portion of it sticking out right here, and our salivary glands, which I cleaned up a little bit more. This is our parotid gland, and this is our submandibular. Break, moving to the abdomen. Coming back as soon as I move the camera. Repositioning. So we can get a good shot up into abdominal cavity. Okay. Focus. Okay. Coming back. The next organ of the GI tract is the stomach. See the stomach right here. There are 4 regions to the stomach. The cardia, which is the area right around where the esophagus enters. The fundus, which is the portion that extends anterior to the cardia, superior in humans, lies above the level of the opening for the esophagus. The body, and the pylorus. There are 2 sphincters that border the stomach. Proximal end, we have what's known as the lower esophageal or cardiac sphincter. This separates the esophagus from the stomach, regulates the passage of food into the stomach. At the distal end, we have the pyloric sphincter. That is the sphincter that holds food in the stomach until it's been digested, and then will relax, allowing that food to pass into the small intestine. We have 2 external features. Greater curvature, which is always on the lateral side of the stomach in anatomical position, and the lesser curvature. Now, inside of the lesser curvature, we see a 3rd fold to our peritoneum. We've already identified the first 2, the greater omentum, the fat apron, and the mesentery, which we just cut out. The 3rd is called the lesser omentum, and this is what actually attaches the stomach to the liver, and that helps to hold the stomach in place. In this region, we find our other 3 accessory organs: the liver, 5 lobes, and there's a 5th one tucked in down over here. The gallbladder, which in most of the cats is going to be green because of the bile that's present, but in some it just looks like a little deflated sac. And then our pancreas, which extends all the way over into the curve of the duodenum. Now, pancreas, as part of the digestive system, produces and secretes sodium bicarbonate, an antacid that helps to neutralize acids coming out of the stomach, along with several enzymes that are going to help digest food. On to the small intestine next, which is this mass that we just liberated. Starting at the distal end of the stomach, approximately the first 6 inches of small intestine are a region that we call the duodenum. The remaining portions of the small intestine are somewhat evenly divided. So if we were to put the end of the duodenum against the end of our small intestine, stretch these out, I ran out of camera, but stretch these out until they're somewhat even. From the duodenum here, from the duodenum here to here would be the intermediate segment called the jejunum. And from my finger here to where the small intestine enters the large intestine here is known as the ileum. I-L-E-U-M, not I-L-I-U-M. Again, there's no hard and fast rule. They don't give us any dotted lines to say, oh, this is ileum, this is jejunum, this is duodenum. It's just a regular guesstimate based on the fact that about the first 12 inches in human, or sorry, first 6 inches in human is duodenum, then the next 4 to 5 feet ileum, or next 4 to 5 feet jejunum, next 4 to 5 feet ileum. And then we have our large intestine. Now this large intestine, since we've removed the connective tissue that helped to hold it in place, kind of hard to tell which end is which. There are only two ends that we really need to be concerned with. The cecum, which is our blind pouch, that's where the large intestine starts. It's where the ileum of the small intestine meets the large intestine. This point where the two come together is known as the ileocecal junction. The other portion is the rectum, which is this portion of the large intestine that goes down into the pelvic cavity. And then, of course, if we flip the cat over, the anus would be the opening that fecal matter would come out of. And review. Internal jugular vein on the right side, and our right external jugular vein. From the left subclavian vein, we have our left internal jugular vein and our left external jugular vein. The small branch that comes off of the, oh my God, I think I called these subclavians. I did. Okay, we have to redo venous structures. As for the venous structures, we have our superior vena cava, which then branches into a right and a left brachiocephalic vein. Off of the right brachiocephalic vein, we have our right internal jugular vein. Our right external jugular vein. Our subclavian vein, which is extremely short. This branch starts on one side of the rib cage and ends on the other, so it is extremely short. Into our right axillary vein, and then into our right brachial vein. From the left brachiocephalic vein, we have our left internal jugular vein, our left external jugular vein, our left subclavian vein, and again you can see just how short that segment is. Our left axillary vein, and our left brachial vein. Now I'm going to go ahead and reposition the camera and pick up with the arteries and veins in the abdomen. So just come around and do that over here too.